afternoon, everybody. Thank you so much for joining us for um, this episode of the PINE series. Our PINE webinar is called The Complicated Case of Cystic Fibrosis, and I think it's going to be a really great discussion. So thanks again for being here. I'd like to introduce our guests. Thank you so much for joining us. First of our presenter is Dr. Eric Pauly from the University of Virginia. He's a senior fellow with an interest in CF. Our experts are Dr. Jerry Nick. He's a professor at the National Jewish Hospital. He's also a director of the CF program at National Jewish and also of the National NTM, National Jewish NTM Core. And then we have Dr. Alpon, who is an associate professor at the University of Virginia, and she's the director of the CF program at the University of Virginia. So thank you so much again for being here. This is meant to be an interactive webinar, so if you have questions, please either post them in the chat or raise your hand and unmute yourself to ask questions. And I think we can go ahead and get started. So Eric, please take it away.
Awesome. Thank you so much, Ava. I really appreciate this opportunity to be able to come and talk together like this and share this very interesting case and get some very good discussion going about this one person in particular, but also kind of the decisions that went into the treatment and kind of how to generalize this to patients that we may see in the world of advanced infectious disease and in cystic fibrosis. So I think just to kind of give a little outline for how we're going to proceed today, I'm going to start with the case presentation, at least the first part of it, then we'll go into some clinical information relevant to the case and a little bit of background. Then we'll go into some of the treatment decisions that were made, coupled with a review of kind of NTM disease, NTM-PD at the end, and then we'll open for questions. All right. So let's start with meeting our patient. This is a very pleasant 23-year-old female with history of cystic fibrosis. Now she has delta F508 and N1303K mutation with asthma, mild intermittent. On top of that, she recently transitioned from the pediatric pulmonary clinic to our adult clinic. She has unfortunately numerous exacerbations every year, requiring multiple courses of oral and IV antibiotics. And she responds to treatment, but shortly after the treatment courses are completed, she begins to relapse and usually just kind of slowly rolls into the next exacerbation. She is employed as a desk clerk at a local business. She's never been out of the state of Virginia, which is relevant because we're kind of right here in the center of the asthma belt. We're also very wooded and rural. There's a host of allergens and environmental molds and spores just because we're in this very verdant, humid area. And she also has a dog for a potential allergen for that asthma. She's colonized with MSSA, Pseudomonas, Aspergillus, and Exophiala. Her daily therapies for her asthma and for her CF are levoalbuterol nebulized daily, hypertonic saline 7%. She uses Dornase alpha for mucolysis, and then she's on aztreonam and tobramycin nebulizer therapies, and she switches between one of those every other month. She feels better today, but she just completed a course of Pip/Tazo for a right upper lobe pneumonia. This was her second IV this year and her 7th exacerbation in this calendar year. This was in October of the year we saw her. She also has a history of massive hemoptysis, which is important later in the management of the patient. And she recently started amphotericin B nebulized therapy for that as well, simply because it was thought to be due to the aspergillus that was kind of worsening her hemoptysis. All right, so this is her FEV1 graph over time, over the 5 years prior to her presenting to clinic for the very first time for us. So if you look at the last dot on the right, that's when she came to us that day. But if you see just back in time through the last 5 years before this, she's had many ups and downs, and numerous times throughout each year, she kind of skates back and forth. Now she can get up over an FEV1 of 90 when she's on a good day and not exacerbating, but then she frequently drops, sometimes down into the 70s and once even to 69. So you can see how just a very variable course, no consistency, and just frequent exacerbations. This is her chest X-ray at that first visit. As you can see here, the most important thing to take away from this is on the right upper lobe, you see what is the beginnings of significant like bronchiectasis and scarring. You can even see some just very focal destruction of architecture there with a little bit of consolidation emerging around it, but it's very focal in that right upper lobe. This is a CT from prior to her first visit with us, actually at the time of that previous exacerbation requiring the IV antibiotics. Both images here, same slice, but what you're seeing is just a recapitulation of what we saw on that X-ray. It's very focal disease. You can see just dense white destruction, as well as a little bit of tree and bud nodularity there in the apex of the right upper lobe, but significant for focal destruction of that region of the lung. All right, so this opens up to the very first question, and Tanya, if you could help us with this. What would you all do if you had this patient present to you in clinic? Would you order a CT chest at that visit to better characterize the right middle lobe in bronchiectasis as previously seen? Would you perform a bronchoscopy to rule out other infectious agents which could cause that persistent right middle collapse? Or would you pursue a workup for primary immunodeficiency with quantitative IgG and CD4 counts or some alternate infectious pathology?
Okay, I think we can move on to the answers.
So for this one, we kind of opted to go with both A and B. So a new CT was ordered at that visit to kind of recharacterize what we had already seen on the prior imaging. And we had tentatively planned to perform a bronchoscopy to figure out if there was any other infectious cause driving that focal destruction of that right upper lobe.
Eric, I'm going to pause here and just ask Dr. Nick and Dr. Alban, what are their first thoughts when they see a CT like that in a patient with CF? Perhaps Dr. Nick?
Yeah, no, I mean, I think, first of all, apparently this was prior to CFTR modulators. So, in classical, severe CF, you often do see right middle lobe, right upper lobe collapse. And that can, it can be from a variety of organisms. You can definitely see that from Pseudomonas by itself. And you don't see it quite as much with staph, but it can also be non-tuberculous mycobacteria as well. The differential of invasive aspergillus, that's not typically seen in people with CF with milder lung function. It can be a very, very late stage complication, but this could definitely be simply Pseudomonas, or it could be other infections as well.
Dana, what were your thoughts?
Yeah, so the reason I decided to pursue bronchoscopy and other organisms was that she partially responded to the treatment for Pseudomonas. And instead of that area getting better, it kept getting worse. So instead of seeing an improvement, we kept seeing worsening and worsening of her symptoms and exacerbations. So we thought it's a good idea to pursue other organisms just to understand a little bit better if anything else was playing a role. Like Dr. Nick said, like NTM was a concern, especially with the hemoptysis.
There's a comment and question in the chat from Dr. Epstein. Immunoglobulins should have been done at some point for workup of bronchiectasis, because that's a great comment. And then, were you looking for endobronchial lesion with bronch, or was she not spontaneously productive?
That's a very good point. So sometimes when the bronchiectasis are so localized and we see localized architectural destruction, we think of possible endobronchial lesion. However, despite being the sputum, for example, being productive, we cannot rule out the second organism. A lot of times, I don't know if it's the same at National Jewish, but a lot of times at our microbiology lab, when we perform AFB cultures in patients who have a very high bacterial burden, the AFB cultures are overtaken by oropharyngeal or flora or the pathogens that they are currently growing. So I really think sometimes can be difficult with just sputum samples to identify NTM. Most of the times it's fine, the regular sputums, monthly or even more frequently every time the patient has sputum production are good enough. But sometimes when we have suspicion that something else is going on, maybe a bronchoscopy may be a good idea. Dr.
Great.
What do you think? How strongly would you feel about bronchoscopy versus not in this situation?
Yeah, I mean, it's always good to get more data that, especially in these people that are frequently exacerbating, they're on antibiotics a lot. So you can suppress your cultures even further. And certainly, when people are co-infected with Pseudomonas, there's a lot of overgrowth. So the sputums have to be decontaminated and you lose a lot of sensitivity from your sputum cultures due to the decontamination process. So in our clinical trials, people that have NTM disease, we see between 33 and 66% positive cultures. So there's a lot of false negatives. And so bronchoscopy is definitely not a bad idea.
Thank you both. Eric, I think you can go ahead.
All right. So while that decision was being made to pursue bronchoscopy, she ends up coming back to clinic. This is very short interval. This is within 2 weeks of that first visit. Unfortunately, this time she has symptoms of exacerbation. Her respiratory viral panel at that time is positive for rhinovirus. She gets another chest X-ray, which continues to redemonstrate the persistent right middle lobe loss. And her PFTs demonstrate a 6% decline from 83 to 77%. So at that time, we decided to start her on a course of amoxiclav and ciprofloxacin for 2 weeks. But unfortunately, 1 week after starting that, she had right-sided chest pain with inspiration and had another episode of hemoptysis with about 60 cc's of bright red blood. All right. So this is that chest X-ray at the first visit that we've already shown, and then this is the second one. And what you're seeing is a persistent worsening of the same known problem with maybe a little bit of some air bronchogram there that's new with that arrow sign. But other than that, it's just worsening what we already knew. We're seeing more airspace disease presenting up in that right upper, continued volume loss to the right middle. This is the CAT scan of that same interval time. And what you see there is that apical section of that right upper lobe is now almost totally gone as far as viable lung tissue. You can see even some, what you can call those air bronchograms there on the axial sections where you can actually see them extending all the way up to the periphery of her lung. Just thoroughly scarred, thoroughly bored open, nothing viable there either. Let's see. So she continues exacerbating. We continued her on amoxiclav and ciprofloxacin, and then voriconazole was started as well. And this was done because we thought that this was aspergillus that was just worsening and that we needed to cover her, given the fact that she was now having hemoptysis as well. She did not tolerate the voriconazole, unfortunately. She had QTC prolongations, and we had to discontinue that. And then after a brief period of insurance clearance and everything else, she was able to get started on isavuconazole. And then we were able to do the bronchoscopy when she was a little bit better after a week. So she cleared the viral illness, cleared that exacerbation, then we were able to go in. So this is the
I just
bronchoscopy
gonna
findings.
pause you. Sorry,
Yes.
there's a question in the chat, but with the
Sorry, it's a small enough group. I might as well just say this out loud. Yeah.
yeah, that's
But,
totally better. Yeah.
Yeah, no, I was just wondering. I mean, people, I sort of see this, people do this a lot, right? Where people sort of start an antifungal, but I don't know, it's often helpful to sort of say explicitly what you're treating, right? Like, was this ABPA, or were you actually calling this a form of chronic pulmonary aspergillosis, like chronic cavitary pulmonary aspergillosis, which it didn't look like that in the CT, but were you calling this invasive pulmonary aspergillosis for some reason? Yeah.
The Eric or
Okay.
Dana.
Oh, okay, yeah. So it was, I mean, there was concern for invasion. With the new hemoptysis, there was concern for some possible angioinvasion. So the decision was to treat aggressively and early before conazole. Yeah, certainly no chronic cavitary. ABPA was brought up at one point as a possible reason, but the CT pushed us away from that simply because it was just so much worse so quickly. The interval on those is less than 2 months on those two CTs. So given that it was thought that it was rapidly invasive, she was quickly deteriorating, and we wanted to get out in front of it quickly with an antifungal.
I want to add to that. So her IgE and eosinophils did not support the ABPA,
Mhm.
and her fungital and Aspergillus galactomannan were positive with positive cultures. So that usually when I see both, so Aspergillus galactomannan plus fungital positive, I have more of a concern of a more invasive Aspergillus disease. But that has been kind of my practice, especially with hemoptysis, if we don't have another organism that explains the hemoptysis.
Okay, great.
Hmm. So
Eric?
this is the bronchoscopy, and I wanted to take a moment here and let Dr. Albin, who was the one that was able to perform this bronchoscopy, kind of talk us through the whole experience start to finish. But the pictures here are matching with the diagram there adjacent. And she was found to have about 75% occlusion on that right middle lobe takeoff. Yeah, the BAL at this point was taken from the right lower lobe lateral basal segment. Only about 63 cc's were instilled, and then 23 cc's came back. Then a second suction sample was taken from the right middle lobe and sent for bacterial, fungal, and AFB cultures as well. Dr. Alvin, do you have any thoughts or any other remembrances of this bronchoscopy at all?
So I think bronchoscopy is very helpful, and I like to do my own bronchoscopies because it tells me, one, how abundant the secretions are, the quality of the secretions, and as you can tell, she has almost nothing, almost no secretions, no mucus production. The mucosa also, it's important to evaluate. She has no endobronchial lesions. She has no evidence of anything endobronchially that would explain the hemoptysis. The mucosa looks a little bit friable, red, and it's not very shiny. In certain areas, it's a little bit shiny, so looks a little bit inflamed, and there's no blood. So it tells me a lot about how well the patient does airway clearance, what the secretion quality and quantity is, and if there are any endobronchial lesions or anything that would explain the hemoptysis. The other thing in this case is the narrowing at the right middle lobe did not seem to be an endobronchial pathology. It seemed to be compression from, like from her architectural destruction and what we were seeing on the CT scan. So it was very, very helpful to do the bronchoscopy myself and to look at what exactly the airways look like.
All right. Thanks, Dr. Albin. I appreciate that. So shortly after the specimens were sent, Mycobacterium abscessus was recovered. Washings from the right middle lobe and lower lobe were positive for Mycobacterium abscessus, subspecies abscessus. The BAL was also positive for Staph aureus as well as Aspergillus, which were known colonizers in this patient beforehand. And her PCR viral, ironically, was negative just 2 weeks after being positive for rhinovirus. Genotyping and susceptibility studies were then sent out to National Jewish for kind of treatment decisions. And then the azithromycin that she had been on was discontinued for potential use in the future as part of NTM-PD therapy. All right, so this is just a table of the susceptibility results as they came back from National Jewish. Just to help everyone understand, in case this is not familiar immediately to everybody, but S stands for full susceptible, T is tentative susceptible, and then TR is tentative resistance. And then, so for this one, I mean, she was amikacin sensitive, clarithromycin sensitive, clofazimine sensitive, tentatively, kanamycin and tigecycline tentative sensitive. Now, the thing that's important to take away from this particular slide and this particular result is that she was also ERM41 gene result positive. So taking clarithromycin sensitivity as a confirmed sensitivity is a little bit hard to do when ERM41 represents inducible macrolide resistance. And if the bacteria expresses ERM41, then you are not likely to have great success treating with a macrolide, even if it shows susceptible on its culture data.
I think Dr.
So,
Adams has a question whether possible meaning functional ERM gene present.
I'm sorry, I missed part of that.
Just
Dr.
positive, I assume means just there was a functional ERM41 gene present, right? It wasn't
Yes.
truncated or, oh, okay.
No,
okay.
no, it was, so yeah, the gene breakdown products is what that test was actually checking for. So with ERM41 gene product, it's actually showing the protein being, the protein is being made that demonstrates that there's an intact ERM41 being transcripted off of the genome.
And this was like this was like the 5-day or forget, I think it's the short incubation period is like 5, right? Is it 5 days?
Yeah, it was very
okay.
quick. If I can remember correctly, I think it was something within 9 days to go all the way from Virginia to National.
Oh no, sorry. I just mean that this wasn't the prolonged incubation of the clarithro, right? This wasn't the 14-day.
No. It was that's what I'm saying is within
okay.
2 weeks, the whole thing was sent, resulted, and came back. And we were
Oh,
doing
I see. Okay.
off of it. So it was definitely the short term, All right. So for everyone in the audience, this question is, what therapy would you start for this patient at this point? So rather than reading all of these out loud, I'm just going to bring them onto the screen. And you could open the poll. There we go.
Anna, can we see the poll results or?
All right. Well, everyone got it correct. The rest of those regimens are not legitimate regimens for treatment of NTM. This is the exact correct regimen as we ended up choosing for this patient. So, so she was started on that regimen as well as N-acetylcysteine and vitamin B6 to combat the side effects of that regimen itself. We offered inpatient admission. Patient was very not open to the idea of having to come back in for another admission. So we were able to place a PICC line, and then home health was able to assist her with infusions. She was then referred to our infectious disease group for co-management and for routine lab draws to make sure that she was tolerating her antibiotic regimen. And unfortunately, she had some issues with this therapy initially, kind of the very common issues that most patients run into with this, which was LFT elevations, nausea, and vomiting. She had to have several dose adjustments while she was in that initiation phase of her therapy.
Yeah, just a comment. I mean, I know people don't want to go to the hospital, but when you're starting 5 antibiotics and putting in a PICC line and getting amikacin levels adjusted and the way you want to do this is as an inpatient, and to do it sequentially. So you add one antibiotic at a time, and you see how that's tolerated. You add a second, you add a third, and then when you get into these, issues of nausea and increased LFTs and adjusting the dose, then you can figure it all out. And in the long term, it's just so much more efficient to do it in the hospital. And you just kind of have to, at some point you just have to say, we can't do this at home. And we've been in this situation many, many, many times, and it's just really hard to do this at home.
I have to say, so I'm at Stanford. We do this we actually do it a fair amount at home. I mean, it's a pain. It's a real pain for us, but I do a fair amount of we don't have huge volume. I mean, maybe if I have a few abscesses patients per year or something like that, but yeah, we often actually do it at home, like just with home health. A drug every 5 days or every week or something with weekly labs, but it is a real pain. It's hard to do. The drug levels are often done wrong. The patient has to, home health doesn't want to wait around for an hour to draw a trough and then a peak. Like it's doable, but it's just a real pain.
It's very interesting because our ID physicians, so it's complicated. Our ID physicians would usually like to start everything together because they are concerned of resistance. So they want us to start everything together.
Not over a few days. I mean, not over, we're talking short periods. Yeah, not like,
Yeah, there is a little bit of a push to start as many as possible together. And then, yeah, just to answer like home versus inpatient, most of our inductions are inpatient. But she absolutely hated being in the hospital. And I think Eric said that she was transitioned from the pediatric group, and she was so used to be treated for exacerbations with IVs at home that she refused hospitalization. So we couldn't do it in the hospital. But in general, we do it in the hospital too, especially for amikacin adjustments. We no longer use tigecycline. I think Divya asked in the chat about other regimens. I actually have not used tigecycline in a while because of all the LFTs elevation, and it's very poorly tolerated. We do use amoxicillin, even though it's very difficult to get it from like insurance pre-authorization is very difficult to get, but we were able to get it. And then also we are kind of moving away from using linezolid and using tadalafil, and we do use clofazimine.
Can I ask what the dose is, just because this is like something everyone does differently? I mean, did you do 3 times a week amikacin at what dose, or do you use daily, or? I mean, yeah.
For most of our patients, we use daily. For cavitary MAC, we use 3 times a week, but I think every center is different. So Dr. Nick, what's your experience?
Yeah, we dose the amikacin for adults 3 times a week. And it's not a high dose, it's 15 to 20 milligrams per kilogram. And then I definitely agree, like the Tigecyl is tough, and if you can get them at it, it's definitely much better tolerated, probably superior MICs. Tadalafil's definitely superior MICs to linezolid and better tolerated. And then, now with CFTR modulators, clofaz has kind of become the backbone of treatment for both MAC and abscesses for our CF patients. So, clofaz, you get nice synergy with the amikacin, and it's free and it's well tolerated and it's an oral drug. And so, we really depend on clofaz nowadays. And imipenem, I would definitely include imipenem as one of the initial drugs. I think it's good to have a cell wall agent. The MICs didn't look spectacular, but that's usually what MICs for imipenem are usually in that intermediate range. But I would always, try to keep that as part of the induction phase. And then, of course, the azithromycin was not an active drug in this case. It's a little, you can keep azithro if you think it's a valuable modulator, immunomodulator for Pseudomonas. The problem, though, is that if you're getting into an issue with QTc prolongation, azithromycin is just one more drug that can do that. So you kind of have to, a lot of times we leave it, but a lot of times we don't.
Okay, great. Eric, I think we can keep going.
Sure. So we're going to briefly switch gears just for a moment and talk a little bit about non-tuberculous mycobacteria as a disease class. We'll talk about the epidemiology, pathogenesis, how to diagnose, treat, specifically the population of NMPD in cystic fibrosis, and then we'll go back and wrap up our patient's case there. So just some epidemiology statistics and facts. There's been over 200 species identified in the last 70 years, endemic to soil and water all over the continental United States. The prevalence now of NTM in general is about 16 per 100,000 persons, which is twice what it was in 1992. So it's rapidly climbing, and there's many theories as to why that is. Some with climate change and just shifting growth and some of the mutations that are happening in the bacterial populations themselves. Traditionally, the species have been dichotomized into a rapid or slow-growing group as they behave on their growth media. Unfortunately, also NTM is now found in the plumbing of most American homes. Its biofilm allows it to resist heat temperatures up to 130 degrees Fahrenheit, which is kind of at the upper limit of what's safe for a home water heater to be set for anyway. So as a result, most people have at least some NTM growing in at least one of their fixtures in their home. Until the 70s and 80s, I think it was like 1983, NTM was kind of largely thought to be only southern United States, given the humidity and the climate profile down here in the Southeast. But it was really, I think, in the early 80s with the advent of HIV and AIDS with the immunosuppressed population showing that you could get NTM infections almost anywhere in the country if you were susceptible. That kind of changed the thinking about that. So Dr. Nick, I wanted to take a second and just ask you what your experience is with non-tuberculous mycobacterium out there in Colorado, and just is it as prevalent there as it is here? And if so, have you guys tracked it or had any luck kind of minimizing it or minimizing patient exposure to it if they're at risk?
Yeah, no, I mean, every people that have NTM are justifiably kind of obsessed with where they got it. But I mean, it really is ubiquitous. And there's good data that it's more common in areas with higher humidity, higher surface water tension, pressure, close to, water features, close to lakes, close to the ocean, and in places like Hawaii, abscessus is the highest. In places like Louisiana, parts of Central Florida, but it's definitely everywhere. And then there is, a high correlation with water supply systems, in particular the MAC species. But there's no reason to think abscessus isn't in the water supply either. And so I don't, it's definitely, when people get NTM, it's not bad luck. I mean, it's because it's everywhere, and we're all being exposed to it on a daily basis. And I think there are some behaviors that have been fairly well established as being more risky in people that are vulnerable. If you're not in a vulnerable population, you never get NTM. But if you're in a vulnerable population, then there's been a link to gardening. We've definitely seen a lot of association with being in a dusty environment, people working in agriculture, kids that are on the farm and the rodeo, stuff like that. And then indoor hot tubs, we've seen an association there. But in general, you know, it's just everywhere. And it's, if you're a susceptible person, it's going to be very hard to avoid.
Thank you. I really appreciate that. So moving forward, you know, talking about NTM-PD itself as its own disease, it's the most common presentation of NTM infections. Unfortunately, the other common variants that you would see would be like lymphatic disease, skin and soft tissue infections, and then there is a disseminated form, which is thankfully the most rare and also the most severe. NMPD regularly co-occurs in patients with structural lung disease, notably bronchiectasis of any etiology, CF, COPD, pneumoconiosis, prior tuberculosis.
Eric, I think we lost you for a
Anomalies.
second.
Sorry?
I think we lost you for a second, but you're back now.
Oh, sorry. Yeah, physical anatomic anomalies as well. Scoliosis, pectus excavatum, mitral valve prolapse, hypermobility syndromes. They're all associated, including like Ehlers-Danlos, things like that. They're all associated with NTM presence in the respiratory tract, sometimes independent of actual structural disease, but as a recovered culture flora. All right. So this brings us to our third question. What are the ATS current criteria for diagnosing a patient with NTM-PD? So clinical symptoms plus a single culture, 2 or more sputum cultures with the same species of NTM growth plus symptoms with associated CT findings of multifocal bronchiectasis and nodules, bronchoscopically recovered lung washing regardless of patient symptom status, or an open lung biopsy to confirm. So this is time for a poll the audience.
Yeah, I think we can move on.
All right, thanks everybody. I guess I can't see the results, but I will just go ahead and say, yeah, everyone has correctly identified that it is the second option. The 2 or more cultures with the exact same species growing plus symptoms of disease and a CT finding that supports structural damage. So M. abscessus as a disease, 10 to 20% of all patients with cystic fibrosis will at some point develop M. abscessus or M. avium infection at some point in their life. It's the number 3 most commonly recovered pathogen in the United States. Often like Dr. Nick was saying, around water supplies and at home plumbing. Indoor water heat, indoor water, hot tubs are kind of the big thing. There are 3 main subspecies now identified and treated as individual species. It would be Mycobacterium abscessus, Belletii, or Massiliense. And then the pathogenicity is differentiated by the presence or absence of glycopeptidolipids in their cell walls. Previous infection or colonization with Pseudomonas is a separate condition, which this patient that we're talking about actually had, which increases your risk of M. abscessus infection. Radiographically, the appearance can be fibrocavitary, like TB, or nodular bronchiectatic, like we were seeing in this patient, if you recall the CTs that we started with earlier. High-res CT is now the preferred imaging modality to assess these structural changes, although large fibrocavitary disease is even visible on chest X-ray, as we saw with this patient. Specifically in patients with cystic fibrosis, there's evidence that Mycobacterium abscessus can undergo horizontal gene transfer, acquiring resistance genes from other commonly found colonizers like Pseudomonas and aeruginosa and Burkholderia, which presents significant treatment barriers, including MGTC, PLC. They're all found co-expressed in all 3 of those bacteria, and it's thought that they can share back and forth with each other. And when the NTM species obtains these genes from transfer, it makes them much harder to treat. So let's see. So genotyping is the most important tool we have now once we diagnose the presence of non-tuberculous mycobacterial pulmonary disease. Once we diagnose it, we frequently will have a discussion with the patient, you know, about goal-directed therapy and whether or not we just watch and wait, especially if this patient's elderly and has bronchiectasis and has relative poor quality of life. The arduous task of getting them on up to a year or more of antibiotics and the side effects with those medications oftentimes represent you know, significant barriers to want to initiate that with a patient. But with cystic fibrosis patients, these patients are almost exclusively young and have many potential years of life ahead of them, and we want to treat so we can minimize the progressive damage that will inevitably occur over time if we don't treat these patients.
So Eric, I'm gonna maybe pause here and just ask Dr. Albon and Dr. Nick, what sort of goes into the decision whether to treat NTM in a patient with CF, and what would kind of push you more towards treatment? Because I imagine it's sort of difficult to distinguish exactly whether the symptoms are due to CF or whether they're due to NTM, and then whether the type of NTM culture sort of plays a role in that and the decision to treat or just to watch. Maybe Dr. Albon, do you want to start?
Yeah, I apologize. Like there is an extra noise here that I don't know what's going on outside. I think they're building something. Yeah, so my preference in patients who are symptomatic, they have frequent exacerbations and lung function decline, is to treat once we have 2 positive sputum cultures or 1 BAL culture. With the idea that we would like to, or I would like to attempt eradication. I have several patients with M. abscessus that had several induction therapies, and we tried to eradicate and they didn't, and we are just watching right now. But in general, we attempt treatment in the idea that we are going to eradicate and hopefully will break that cycle of frequent exacerbations. Now, ultimately, is the patient's decision if they like to have treatment or not. And in young patients, I think I tend to be more aggressive because it can have a significant impact on prognosis. And again, like we were talking about this with Eric, when we put this together, Mycobacterium abscessus is a relative contraindication in certain places, even an absolute contraindication to transplant. So I think that also plays a role. How close are they to needing a transplant, or how much time they have can we eradicate? So all those things play a role, and the CT scan findings also play a role. How aggressive we want to be, how quickly we want to treat versus how much we can wait. If it's micronodular disease, we have some time. If it's nodular or cavitary, then we may need to be more aggressive sooner rather than later.
Dr. Nick, do you have any other thoughts on this, or is your approach just similar?
Yeah, I mean, I think it's similar. We, you know, in CF, we don't treat the majority of people that have positive cultures, but you know, if the diagnosis really depends on determining that there's a worsening of their clinical course than you would expect based on their other infections and other comorbidities. So, you know, if it's a patient that is, you know, you follow carefully and they're on good treatment, and then they start having increased frequency of exacerbations like this patient and accelerated lung decline, then it's pretty easy to make the decision that if they've had 2 or more positive cultures, then they need to treat the NTM. You know, a lot of times though, you know, we see people that have Pseudomonas, they've got staph, they've got diabetes, they might have ABPA, and you need to make sure that all these other conditions are under good control. And then if at that point you're still seeing accelerated decline or frequent exacerbations, then you make a decision to treat. But right now, you know, with the CFTR modulators, we don't see so much of this clinical symptoms, and so we're kind of reevaluating our approach. And And it is, turning into more culture dependent, the people that are presenting with a lot of positive cultures, then that pushes us more towards treatment than it used to in the past, because the clinical symptoms are kind of suppressed by Trikafta.
Okay, great. There's some comments in the chat. I don't know if Dr. Epstein wants to.
Oh, just that I don't know if you guys know about this Paratech trial. Steve Ross at Stanford is enrolling in it. A few other centers are. I think it's meant to be like a compromise. It excludes CF, right? So it's not relevant in this case, but it's meant to be a compromise between sort of standard therapy and no therapy. It's just omadacycline monotherapy, which I can't imagine that possibly working. I don't know how this trial actually got. I don't know what Paratech was thinking or how the study actually.
That's terrifying.
I mean, you just think it's Shoshana immune resistance, you mean, or what? Or just that?
Yeah.
I just think it's like placebo. I mean, I just think it's placebo. There's just no way it's going to do anything. I mean, it's not even it doesn't even seem like a very potent drug for abscessus, but whatever. Yeah.
Yeah, well, I think the clinical design is most of these trials that they're starting now, they're doing a run-in like with a single drug and then going into guideline-based therapy after a number of weeks. I mean, the issue is if they're going to try to get FDA approval for treatment, they need to show activity as a single agent. But it is at the same time kind of alarming to think, that's not our practice to treat with a single agent.
There's a petroborole, which that trial for refractory MAC was recently interrupted, but it has activity against abscessus in vitro. So I don't know if the company is going to try that route or not. But yeah, abscessus trials are so much harder, right? Because the therapies are so, there's no standard there isn't the same kind of standard backbone necessarily that that MAC treatment has. So
yeah, no, I mean, there's no approved drug for abscessus, so you can't really combine a drug on a trial with other drugs that are not approved. So I mean, that's the study design becomes really, really problematic. And so what we're left with is off-label use, which we're accustomed to doing. We have Amato, we have bedaquiline, we have Tadazolid, we have Clofaz, but they were all approved for other uses, and we're using them off-label.
Yeah, it just sounds kind of odd to do it for 6 months. Like a run-in makes a little bit of sense, but I see what you're saying, that you need to prove that there's activity. Going back to the starting treatment, like when you start treatment, I am sorry that I joined a little bit late, but for this case, I was curious your thoughts of other symptom etiology, kind of like what Dr. Nick was explaining, since she had very localized right middle lobe collapse. Sounds like you were concerned for invasive fungal as well. If you felt that she had adequate treatment for invasive fungal prior to starting abscessus, or if you had any other thoughts of what other etiologies of her symptoms could have been.
Yeah. It was, I mean, she had never grown anything in her previous cultures that was particularly scary, as far as she had pan-susceptible staph. She had Exophiala and Aspergillus, and then a very benign Pseudomonas culture. But it was really just the frequency of the exacerbations coupled with the rapid decline. I started with a CT from her initial transition of care visit into our adult clinic, and then one within about 2 months of that transition, just showing basically total obliteration of any viable right upper lobe parenchyma. And so it was a very rapid decline coupled with this extremely tumultuous, just up and down, 7 to 10 courses a year of antibiotic therapies, with just chaining one exacerbation after the other. Made us think that there was something that we weren't seeing and that we were not adequately treating. Now, she did have, like you said, the hemoptysis event. She'd had several before that, but had only recently started Vori and then savuconazole for about, I think it was maybe 3 weeks when we got the bronchoscopy results back. And the interval time between the bronchoscopy resulting and the treatment initiation was about 2 months. So we went back and forth for 2 months with the patient to see whether she would even want to start therapy, whether it was appropriate. She had that entire time to continue with the voriconazole and never improved. She continued to do poorly. And I have some graphs coming up later when we return to the case that shows that she just wasn't getting better in that 2 months, and that's why we opted to treat. And Dr. Alban, is there anything else that happened in that interval? I think that was pretty much everything that had gone on between bronchoscopy and the time that we started these medicines. Does that kind of answer questions? Okay.
Yes, thank you.
Oh, thank you. Yeah.
Eric, we have about 5 to 10 minutes, so
Perfect.
we
We're
can
doing
try to
well with
wrap
that.
up. Yeah, sounds good.
So we've already kind of covered all of this, and I guess for the sake of time, we can save this for those who would watch this webinar later as a podcast. But the answer to this one is really just after a careful risk versus benefit discussion with the patient about treatment options and the fact that they're symptomatic, that's when you opt to proceed with treatment, which is what we did here. Just briefly to share with everyone, this is a direct retrieval right off of the Cystic Fibrosis Foundation's website. And the most important thing I wanted to convey with this slide is that there is only expert level consensus amongst cystic fibrosis specialists about how to treat these patients in particular, and differing to the ATS guidelines is acceptable and kind of the standard of practice in the cystic fibrosis realm. So we can talk about this if everyone wants to, but this is just the standard therapy. Intensive phase should be initiated with the macrolide in conjunction with amikacin, plus one or more of the following drugs. And we've kind of already talked about the regimen that was used in this case. Then the continuation phase should be for as long as is necessary, up to a year and sometimes even longer. But really the intensive duration is dictated by how the patient responds. And in this case, which we'll show her in a moment, she really only ever tolerated the intensive phase and was never able to move to continuation phase of therapy.
She was, Eric. She moved to
She was able to get to continuation
Yes,
in less than 2 months? Okay.
So induction therapy, usually we do 3 months or a little bit longer. We are trying to attempt to get negative cultures, and then we initiate continuation therapy. Usually it's oral antibiotics for 12 months or longer after, depending on when the last positive culture was.
Right. What I mean, well, we'll talk about it in a moment. So another question here for the sake of time, the preferred treatment was we've already discussed. It is ATS guidelines are generally sufficient. There is no preferred therapy in cystic fibrosis patients specifically. They pose a unique challenge, the cystic fibrosis patients do, simply because their symptoms of an NTMPD overlap with CF exacerbation symptoms. So it's hard to tell what you're actually seeing in the patient clinically. There is no widespread study that has been conducted since CFTR modulators have come on the market to see if they have any effect on NTMPD as a incidence and severity in the population itself. The other big issue, however, with CFTR modulators is the hepatotoxicity and the drug-drug interactions between the standard therapies for your NTMPD patients can often present significant challenges in dosing their medications. This patient was, I guess, fortunately not on a CFTR modulator at the time that she was started on this therapy. So it was not a problem here. So in patients with CF, every 4 to 8 weeks, you should repeat your cultures to assess their response. The serum amikacin levels, which we've already talked about earlier in this talk, should be checked regularly. Like we said, 12 months beyond culture conversion is when you should treat, and that's defined as 3 negative successive cultures. There is no antibiotic regimen, however, that is reliably shown to cause culture conversion. Dr. Albin mentioned this earlier as well, but prior to initiation of therapy, you should assess for any radiological response to see if there's any restoration of tissue architecture and if any of the bronchiectasis has been improved over time. If a patient was eligible for transplant prior to M. abscessus diagnosis, they could still be considered for transplant if you can eradicate the bacteria. Unfortunately, NTM-PD does constitute a relative and sometimes absolute contraindication to transplant, depending on the center and depending on their experience with taking care of these patients. So back to the case, this shows her first visit. Every data point after that was every visit after the initiation of her or treatment of her next exacerbation, then diagnosis and initiation of treatment for her M. abscessus. She continued on this therapy for about 1 month and was still having some difficulty with LFT issues and significant amikacin toxicity, just nausea, vomiting. Her lung function was continuing to decline, and she was also having episodes of hemoptysis still. So at that point, we decided to pursue focal lobectomy since the disease was so focused. And after kind of discussion with our thoracic surgeons and discussion about whether or not to send the patient to another center, at patient's request, we did it here at UVA. She had a right upper lobe lobectomy and a right little lobe segmentectomy. And this is about 2 months after she started her anti-NTM therapy. So as far as surgical treatment of NTM-PD, certain patients with focal disease can be considered for this surgical treatment if the patient is a candidate. Now, candidacy, reasons to consider would be poor response to therapy, resistance to macrolides as this patient had, or continued severe complications from the disease, which she had in the form of hemoptysis. You should trial antimicrobial therapy to reduce the microbial burden if you're considering surgical procedures for the patient. It's not a well-studied management strategy, however. There's very few centers in the States that are willing to perform this procedure. It has with a high morbidity, even in patients with decent cardiopulmonary reserve, which this patient had. There is no guideline for appropriateness for this procedure since it's rare. And those centers that do perform it tend to just go off of lung cancer resection criteria and whether or not a patient would be tolerating lobectomy in that situation, and they just apply that to the patients they're doing a lobectomy for NTM disease. So the patient underwent the procedure, tolerated it well initially, but while she was in the hospital, she did have a postoperative hemorrhage. She was surgically re-explored shortly after. It was within 5 days of the initial procedure. She was continued on all the mycobacterial therapy while she was there. And this is where tedizolid was started. I know Dr. Albin mentioned that earlier, that we don't typically use linezolid anymore. And this is around the time that she started on tedizolid. So she was able to be discharged about 9 days after the procedure, went home. These are just LFTs immediately pre her lobectomy, immediately post procedure in the hospital prior to discharge. And then this is present day. And what is really, really interesting to show here is just almost no substantial decline in her FEV1, very, very close preservation of her FVC. Overall, she has rebounded quite nicely after the lobectomy. So these are her FEV1s trended over time. This procedure was done several years ago at this point, so we have a wealth of data after the procedure itself. You can see here, there's her first visit we talked about, then her kind of persistent decline through the bronchoscopy, through the diagnosis, through the initial treatment. And then she had her preoperative visit. Then there was the sharp drop for the surgery itself. And then everything after that has been markedly improved. So this is her CT as of about 3 months ago. As you can see, she's had, you would be hard pressed to know that she'd even truly had a lobectomy other than the change in the fissure, but she's had re-expansion of the right middle, and there is almost no structural disease seen in that right side anymore whatsoever. The patient's doing very well. So she began to recover 2 months after the procedure. She was actually able to get married. She did continue on her maintenance therapy. And I think this is what Dr. Albin was saying. What I meant to say earlier was that she never made it to consolidative therapy before we ended up sending her for a lobectomy, but she did manage to tolerate all of that well, and then stayed on for another full 9 months of maintenance therapy afterwards, until she was pregnant. And that kind of forced our hands to terminate treatment simply because she was pregnant. At one point since this whole treatment event, she did grow Mycobacterium avium, but that was on a single culture. It has not been repeated and has not had any exacerbations related to that. She's had 3 other pregnancies now since the procedure and has had no issues with any of those, obstetrically or pulmonologically. And then she's actually most impressively had no CF related admissions, no episodes of hemoptysis, and has not required IV antibiotics. So that's just a remarkably good outcome. Once we removed the focally affected area of the lung, all of her exacerbations cleared up, and she has not had any significant complications with her treatment ever since. So all in all, it was just a summary of a particularly interesting course of care that we had with this patient. Let's see. And I just want to thank everyone for coming and letting us share this with you all. If anyone has any questions about the last part of her treatment there, we'd love to discuss it. I don't know how much time we have now, but I'd just like to open it up and see if anyone has any thoughts.
Yeah, I think we have a few minutes for questions or comments, whether from the audience or from our experts.
Thanks so much. That's a great case. We've done for surgery. We've done at Stanford, like we have general thoracic surgeons, not people who do. We do a lot of NTM specific surgeries. We've done like wedges. We've sent people for wedge resections of like single cavities. Like that's if a single cavity, especially if it's not right, super pleural based, like that's pretty straightforward, I think, for any thoracic surgeon to do. But yeah, it's like especially the extensive consolidations where you need segmentectomy or lobectomy, where things get really messy, right? But if a single cavity with nice normal lung parenchyma around it, that's easy for anyone to do. So I think that's like the exception for this, the rule about how surgery is complicated.
Dr. Nick, do you have experience with the surgery for hemoptysis at Colorado? Or
Yeah, I mean, they do it extensively here. Usually it is in MAC, non-CF, where it's very, very focal and confined usually to a middle lobe. And in those patients, I think they have had pretty good response. There's not really much support in the guidelines for doing this in CF, and in particular with abscessus. And so I think, I've seen quite a few people that over the years have had lobectomies, and it's definitely a mixed bag. There's some people that have had, really good outcomes like this. There's a lot of people that have had, some improvement, but then, within a few years, they're infected again or still infected. And then there, I have seen catastrophic, terrible outcomes too. So, there's a lot of reluctance to put this as part of standard of care. Obviously we treat patients one at a time. So, for an individual, it may be a good fit, but it has to be, it's never a substitute for antibiotics. It's always with antibiotics, and it has to be kind of thought of as part of, a lifetime strategy for mycobacteria. I think we really need to think of, especially in CF, nontuberculous mycobacteria, it may be that we have a triumphant cure, but more likely, it's part of a staggered management strategy that it's going to go on for the life of the patient. And you can, like in this individual, I would imagine that she's on a modulator now, and that's definitely helped stabilize her course. But she's had another positive for MAC, and so there's a lot more story to be written here, I think.
Well, nobody else has any questions. Thank you, everybody. I thought that was a great discussion and a really, really great case. Yeah, thank you, everybody. I hope you have a good rest of your day.